Good afternoon. You have signed on to the New York Medical College, Touro College and University System COVID-19 Continuing Medical Education course. We are expecting up to 700 people to be signing on for today's course. And as those numbers are ramping up on the screen, I will spend a moment telling you how to sign up for CME credit, Continuing Medical Education credit, for those of you who wish to receive it. I will be your host for this afternoon. My name is Edward Halperin, and I am the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. For those of you wishing to receive CME, text the code 25 and then all capitals NIXY to 828-295-1144. You will receive a response with instructions as to how to get your CME credit. If you prefer, go to the website www.eeds.com, click the sign in button, and enter the same code. You might want to take out your cell phone and snap a picture of this slide so you remember the instructions, or take a moment to write them down. Otherwise, I will show the slide again later in today's program after the platform presentations and before the question and answer period so that you can sign up for your CME credit and to do our questionnaire on your satisfaction with today's program. It looks like most of our participants have signed in, so we can begin our program. Well, good afternoon again for those of you who joined us while I was showing the slide about CME credit. My name is Edward Halperin, and I am the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. You are joining us for the New York Medical College, Touro College and University System sponsored course on COVID-19. This is the third one of our courses. We joined you person to person in Midtown Manhattan about 2 months ago for a course as the pandemic was first reaching the shores of the United States. We then joined you again for an online course about a month ago with updates on the epidemic and clinical and public health responses to it. And here we are again for yet another update where we will emphasize antibody testing, clinical pearls, public health responses, what is new in the basic science of the virus, and where do we go from here in trying to restart our lives in the face of the pandemic. What we're going to do differently this time than the last time we were together is we're going to spend less time with you seeing me, giving introductions of our speakers, and more time learning. So each of the speakers will introduce themselves. They will go in sequence of our 6 speakers. Then I will reappear on the screen with our question and answers with the questions that were asked by you, members of the audience, who submitted your questions online in advance of the meeting at our pre-designated website. So let's learn what's new about COVID-19 and what we yet need to know about the virus and our clinical and public health responses to it. To begin our program, we will have welcoming remarks from the president of the Touro College and University System, Dr. Alan Kadish. Dr. Kadish, the floor is yours.
My name is Chandrasekhar Bakshi, and I'm an associate professor in the Department of Microbiology and Immunology at New York Medical College, Valhalla. Good afternoon, everyone, and thanks for joining. So today I'm going to give you an overview of what we have learned about the basic science of the virus, which is responsible for causing the current pandemic, COVID-19, and the immune response associated with it. So what we have learned in this last 5 months since the onset of this pandemic, now what we have a better understanding of the basic biology of the SARS coronavirus 2. So this is the name which is given to the virus, which is responsible for causing COVID-19. So as you can see on a simplistic cartoon here, that this is an enveloped virus, And the genome of the virus is an RNA virus. And as you can see, the surface of the virus is decorated with certain glycoproteins. And one of the proteins that has gained attention is the spike protein, as this is the major attachment protein of the virus. And this allows virus to attach to our cells. And we also know that the receptors which are present on the cells, which facilitate the attachment of the virus, and one of the receptors is known as the ACE2 receptors, or angiotensin convertase enzyme 2 receptor, in association with another serine protease receptor, which is known as TMPRSS2. So with the help of these two receptors, which are present on our cell surface, the virus binds to the cell and then gets entry into the cell and then start replicating and produce millions of copies of its own. What we also know about the distribution of this ACE2 receptor, because these becomes the target organs. And as shown in the cartoon, this ACE2 receptor is present on lung, heart, brain, kidney, cells of the gastrointestinal tract, and vascular endothelial cells, as well as testes. The most common symptoms that we have noticed so far with the COVID-19, that is the respiratory, cardiac, and neurological symptoms, are because of the replication of the virus in lungs, heart, or in the brain. We have also learned a great deal about the mechanism or the mode of transmission of the virus. And what we have learned is that SARS coronavirus 2 has enormous capability for human-to-human transmission. We now know that this virus is primarily transmitted through droplets from the infected individual from his or her cough or sneeze. And these droplets can travel a distance of about 3 to 5 feet. And that's why the social distancing assumes a great significance. We have also learned that pre-symptomatic individuals, that means those individuals who are infected but are yet to exhibit the symptoms of the disease, or asymptomatic individuals, those who are infected but never show the symptoms of the disease, can transmit the virus. So this adds an additional complexity to the transmission of the SARS coronavirus 2. We have also learned a great deal about the immune responses which are generated in response to infection by SARS coronavirus 2. And what we know that the exaggerated and prolonged innate immune responses contribute to the severity of COVID-19. And as shown in this graph, you can see that the innate immune response, which is generated in response to SARS coronavirus 2, has two waves. That is also known as biphasic. So the initial response is the immune response generated by the host by detecting the virus. And the second wave is because of the tissue destruction, which is caused by the virus. So based on the stages of this immune response, the pathogenesis of SARS coronavirus 2 can be divided in 3 stages. So the stage 1 represents the early stage. So that means the infection has occurred. And now the host start responding by generating a viral response against the virus. And this is associated with release of inflammatory signals, recruitment of macrophages to the site of infection, and cytokine production. So this will take care of the virus, or will try to eliminate the virus. And as you can see that this is also associated with a less severe form of the disease. But this stage can progress to stage 2, which is the pulmonary phase, where there is involvement of lungs. And depending on what stage, some individuals may exhibit signs of hypoxia and pneumonia, and some may not. And as you can see that during the stage 2, the viral response is tapering down, but there is another set of immune response, or another wave of immune response, which is amplifying. And this is due to the replication of the virus, which is occurring during this stage, and the damage caused by the virus, or the inflammation induced by the virus. Now the host is responding to its own damaged tissue, and this response is gradually amplifying. And this stage 2 may progress to stage 3, which is the stage of hyperinflammation. And these are all the changes that we notice during this stage 3. So this is associated with cytokine storm. That means there are very high levels of cytokines such as interleukin-6, TNF-alpha, IL-1 beta, and other pro-inflammatory cytokines. There are also elevated markers of inflammation such as C-reactive protein and D-dimer levels. And there is also an increase in the number of neutrophils. So there is neutrophilia, which is associated with reduction in the number of lymphocytes, also known as lymphocytopenia. So what we have learned so far is that this very high level of IL-6 and increased neutrophil to lymphocyte ratios are indicators of the disease severity and the poor clinical outcomes. So this is what we have learned, and to summarize this, that the immune response is the innate immune response in response to the SARS coronavirus is a biphasic one. And how this is linked to the clinical pictures that is observed in the infected individuals. So so if we go to stage 1, you can see that this is where the infection has just begun. So these are the alveoli where the gaseous exchange takes place. There is mild inflammation, and at this stage, the infected individuals are either asymptomatic or paucisymptomatic. And this is the incubation period, which may last from 2 to 14 days. And at this stage, virus may or may not be clinically detectable. And then this may progress to stage 2, which is associated with increased inflammation. And now, as you can see, that these clear alveoli are getting filled with fluid. So that causes a reduction in the gaseous exchange. The infected individuals may remain less severe, and the symptoms of illness may appear, which is associated with fever, cough, and some infected individuals may also experience shortness of breath, which will require hospitalization. And the virus can be detected at this stage. And approximately 80% of the individuals will recover between stage 1 and stage 2. However, individuals with associated with comorbidities may progress to stage 3. So this is associated with this more severe form of inflammation, the cytokine storm, elevated inflammatory mediators. And now you can see that these clear alveoli are now completely filled with fluid, and there is a greatly reduced or hindered gaseous exchange. There is an extensive damage to the lung tissue, and this also causes more inflammation to occur. So this all results in the severe inflammatory response syndrome or acute respiratory disease syndrome. And this is the stage where the patient needs to be transferred to the intensive care unit and may require ventilator and life support. This may further progress to sepsis, respiratory failure, and multi-organ failure. So as we can see that the severity or the prolonged duration of the innate immune response is directly linked to the clinical picture that we see in COVID-19 infected patients. We have also some insight into the adaptive immune response, and specifically the antibody responses against COVID-19. So what has been observed so far is that the antibodies are generated mostly against the spike and the nucleoprotein of the SARS coronavirus 2, as these are the major target antigens for antibody production. And it has also been seen that 100% of the SARS coronavirus 2 infected individuals will seroconvert. That means they will produce antibodies against SARS coronavirus 2. We also know about the timeline or the time course of the production of antibodies. As you can see here in this graph, the IgG levels start to appear after 7 days of infection, the IgM levels, and the IgG levels, they start to appear after 14 days of infection. However, the induction of both these antibody types vary from patient to patient. But both these antibodies, actually, they provide a very solid ground for diagnosis of COVID-19. But as I said, that this pandemic is still in its initial stages, and we do not have a complete picture of the role of antibodies in protection, duration of immunity, and resistance from subsequent infection. So these are some of the things which are not clear to us at this stage. But what is known is that the critically ill patients have a higher antibody titers. As you can see here in this cartoon, in this graph here, that the critical patients have higher antibody levels as compared to the non-critical patients. And this also points to the fact that the antibodies may have a detrimental effect, or it may be responsible for what is known as the antibody-dependent enhancement ADE, which is also seen in other viral infections. So having known or understood this basic biology of the virus, what are the challenges that we have ahead? So the first thing is, like, although the replication cycle of the SARS coronavirus 2 is known, but still we do not have an effective antiviral drug that could prevent the entry and replication of SARS coronavirus 2. I've also shown you that it's the severity of the inflammation, and especially this post-inflammatory response is what caused the damage and the severity of the disease. So we need to have effective therapeutics to minimize the tissue or organ damage, which is caused by exaggerated post-inflammatory response. And New York Medical College has taken an initiative in this aspect and is collaborating with Regeneron for development of drugs that could reduce the tissue or organ damage caused by this exaggerated inflammatory response. We have now some basic understanding of the adaptive immune response, so that may allow us to develop an effective vaccine. But this is also a challenge that lies ahead to develop a very efficacious vaccine as soon as possible. And with this, I will stop here, and thank you so much for your attention.
Good afternoon. I'm Dr. Janet Piscatelli, Director of Pathology and Laboratory Services at Westchester Medical Health Network. Today I'm going to discuss with you the testing for antibodies to SARS-CoV-2, the virus responsible for the COVID-19 pandemic. As a disclaimer, the situation is incredibly fluid. As new knowledge is gained, the points discussed may change, as well as our approach to testing for these antibodies. This is my disclosure slide. Until recently, I was employed by Quest Diagnostics, and I continue to have equity in this company. There are several types of tests which are useful during this pandemic. There are tests for active disease using amplification of viral RNA, which is not the focus of this discussion. I'm going to concentrate on the antibody testing to the SARS-CoV-2 virus. After exposure to the virus, the body fights the infection by mounting an immune response to the pathogen, which it sees as foreign. Some of these antibodies are specific to COVID and can be detected in the serum and plasma of the person after several days. The use of serologic tests, that is the measurement of antibodies, rather than detecting the virus itself, may help in determining the actual number of persons who have been infected with SARS-CoV-2. Around 8 to 11 days after peak viral replication, there are detectable levels of immunoglobulin G antibodies, with most individuals positive after 14 days. The different manufacturers have developed antibody assays to various immunoglobulins, G, A, and M, with different targets. Antibodies to the receptor binding domain of the spike protein and the nucleocapsid proteins are the most frequent targets. However, as each assay is proprietary, there is no consistency and standards, and test results are not comparable. Additionally, there was a push to market, and many of the assays have questionable quality with regards to sensitivity and specificity. Furthermore, in March, the FDA issued a policy indicating that they would not be reviewing these assays, and some really poor tests were marketed, many using lateral flow technology for point-of-care settings. On May 4th, that was Monday, the FDA issued new guidelines indicating that all emergency use authorization assays need to have a full validation performed with documents submitted to the FDA within 10 days. Hopefully, this will curtail the distribution of these problematic tests. There are several ways to detect antibodies in serum or plasma. I just want to go over the two main ones that are used clinically. The lateral flow technology, primarily used for point-of-care testing, and ELISA, of which chemiluminescent is a subtype, which is used primarily in clinical laboratories. This is a cartoon of a lateral flow technology from the Johns Hopkins Center for Health Security. This type of testing is broadly used today for at-home pregnancy tests. It uses a strip technology. There is a spot where the blood is added. Embedded on the conjugate pad are the known viral antigens as well as complex for control for the migration. There is a line of antibodies which capture the patient's antibodies, which has complexed with the viral antigen. And there is a second line of capture antibodies which will bind to the control complex. These lines can easily be read if a reaction occurs. The patient sample is added. If there are antibodies, they will bind to the antigen on the pad and continue migration. A positive will have 2 lines. A negative will only have 1 control line. Either no lines or 1 line at the test site are inconclusive results. These assays are quite rapid, require only a drop of blood, and relatively easy to perform. So naturally, there was a rush to use them. Unfortunately, many were not validated well enough, with issues in accuracy and cross-reactivity. Since they used only a drop of blood, the errors were magnified because of the small sample size and the competence of the people running these assays. The FDA has released new guidance, and these assays will be under further scrutiny. The WHO does not endorse their use, and the FDA explicitly excludes them from home use. ELISA testing is performed in a clinical laboratory using laboratory professionals. Either it is performed on a 96-well plate and read manually, or it can be automated using high-volume, high-throughput instruments. The manufacturers have coated either the wells of the plates or beads with viral antigen. The patient sample is added, and if there are antibodies to these antigens, they bind, creating an anchor. The reaction cup is washed, and then tagged antibodies to the antibody-antibody complex is added. A chemical that creates a light or fluorometric reaction is then added, and the amount of light detected is proportional to the amount of antibody in the patient's serum. Usually, above a certain threshold indicates the presence of antibodies. This is termed a sandwich assay and can be qualitative, quantitative, or semi-qualitative. With these instruments, we can test many people in a relatively short period of time with a single operator. The limit to capacity, however, is phlebotomy. One phlebotomist can only draw about 6 patients an hour. Also, reagent supply can be an issue, but it is less so than with the test looking for active disease. There is so much more that we have to learn about this virus in serology testing. It took us many years to understand the serology testing of hepatitis and HIV, and we are now being asked to draw conclusions after only 5 months of experience. We know that some people who have been infected by the virus do not test positive. This could be secondary to testing too soon after symptoms, as immunoglobulins may take several days to reach a level that can be measured. We should be cautious in equating antibody detection to immunity for a variety of reasons, including robustness of the assays, lack of understanding the profile of the immune response, and some studies have indicated that the severity of the disease mounts an increased immune response. It is unclear that if having the presence of antibodies is enough to provide protection, or if the amount of antibody needs to be above a certain level. If somebody had a mild reaction, now with a low level of antibody, would they be protected? We're not sure. This can even be taken further in that are the antibodies that we are measuring the ones that are involved in neutralizing and killing the virus? All of this needs to be reconciled. Finally, people with antibodies may continue to shed viral RNA in their stool for quite a while. One study determined that there was shedding in a person 47 days after symptoms. Most people stop shedding virus from their respiratory tract, the main route of infection, several days after resolution of symptoms. But positive PCRs, which test for active disease, can persist, and it is unknown if this is detective of active virus or dead viral particles. So why do we test? Well, it's helpful to know if a person was exposed and mounted an immune response. At this point, reinfection is highly likely, and many of the reports that came out earlier from other countries regarding reinfection were most likely false positives. Once a person has tested positive, though, they are excellent candidates to donate their plasma, which may have therapeutic effect to help people currently infected and improve their outcomes. Also, by testing the general population, we can get a true estimate of the scope of this pandemic, the number of people infected, and a true fatality rate. The data will also assist the government to assess the impact of reopening society and when to relax some of the shelter-in-place recommendations, although many states have already taken this risk. By knowing who has developed an immune response, this will give an estimate of the herd immunity and when it is safe to return to work and ultimately remove our masks. We have to remember that this is a new virus, an unprecedented pandemic, and uncharted territory. We don't know for certain whether individuals infected with this virus who subsequently recover and mount antibodies will be protected fully or even partially from future reinfection, or for how long that potential immunity will last. That, along with the variability in the quality of the initial test systems for serology, means that at the current time, these tests should not be used as an indicator for individuals to return to work. Many more studies need to be performed before we can even begin to consider issuing immunity passports. The bottom line is that we will continue to wear our masks and practice social distancing to defeat this virus. Thank you very much. Okay.
Good afternoon. I'm Dr. Robert Amler, and I have no conflict of interest to disclose. The Center for Disaster Medicine at Touro and New York Medical College, which is one of the sponsors of this symposium today, regularly deals with questions that we're talking about today. We deal with community-wide emergencies that could have their roots in biological sources like the current epidemic, chemical exposures or spills, explosive events, even active shooters. And why bring that up? Because in all of these types of emergencies, the first casualty always is information. Information is key. However, information is not the same as data. And in considering data that come in from this pandemic or any other kind of emergency, we have to realize that you can be awash in data with precious little usable information. An example that we are seeing currently is we see a great number of numbers being put out there on numbers of cases, numbers of deaths, numbers of intubations, and so forth. But we hear much less about the rates that those numbers come from or represent. And in fact, numbers are not equal to rates. And that's part of the problem we face in trying to use data to understand the current pandemic as it affects the United States, New York State, and the New York area that we're in. Well, here's an example of data that can sometimes be helpful. Some numbers, not rates, but if we look at the experience up to last week in the New York City and downstate New York counties, we can see the relative numbers of cases coming out of New York City. You can see the red parts of the bars are the large numbers that have really accounted for a great deal of the increase in cases in New York during the current time. Westchester is at the bottom in a light green color, and you can see comparatively how many more cases in New York City get reported versus Westchester, some of the other surrounding counties. Well, of course, New York City has far more people than Westchester, roughly 8 to 9 times the number of people. So it's only by understanding rates that we can really make a fair comparison, comparing apples to apples, oranges to oranges. And sometimes numbers themselves, raw numbers, can actually be misleading. This is a chart that shows numbers of deaths by age group in New York State up to last week. You can see the expected rise that we've learned about seeing more deaths in older people. But look what happens when we get into the very old, people in their 80s and people 90 and above. It looks like somehow the deaths have declined. Does this mean that people over 90 are safer when it comes to coronavirus infection, COVID-19? Well, to understand that, we need to know the number of 90 plus people in New York State, because these are not rates, these are just numbers. If there are fewer people in this age group, we would expect fewer reports of any outcome, including deaths. So we went ahead at the center and we calculated the rates based on population. Now, these are not case fatality rates. These are these are age group death rates from New York State from COVID-19. So these are now rates, and look at the difference. You can see the same rise in populations getting older, but in the oldest age group, you see the highest death rate of all, reflecting the fact that even though there are fewer numbers of deaths, there are fewer numbers of people in that group as well. A very significant observation is possible for the first time looking at death rates by age group, which has not been done until recently. Notice how with each successive decade of life, the death rate not increases, increases, but it more than doubles, from people in their 40s to people in their 50s, people in their 50s to people in their 60s and 70s and 80 plus, a doubling or sometimes more than doubling of the death rate, which really reinforces the extraordinary death risk in these older populations. Will these change over time? Well, they well may change over time, but remember that rates don't change as fast as absolute numbers. Now, the absolute value of these rates, of course, will go up because the population numbers don't change from week to week, but the number of deaths that get reported do go up. But we would expect that these numbers will go up somewhat proportionately. More importantly, if they don't, if they follow a different pattern, that would be remarkable and worthy of further investigation. One more point about this graph. Notice the actual number. These are deaths per 1,000 population. Typically, we report per 100,000 population. So this number here for the 80 and above is actually 900 deaths per 100,000 population, which is equivalent to just under 1% of everybody in this age group in New York State having died so far. We can also use death rates to compare experiences in countries. Remember how it's been reported frequently that the United States has more cases reported than any other country. But the United States also has more population than most countries, and certainly more population than the individual European countries that are represented here. Notice how when you divide by population, in this case, these numbers are per 1 million population. The United States is somewhat in a moderate group in terms of the overall death rate compared to many of the European Western countries. And up here, Belgium, I would have to caution you that there's hearsay that there's something artifactual about the reporting in Belgium, so we're going to disregard that increase. Well, the question really is, what's next? Are we ready for reopening? What about testing? What about immunity, about which we just heard from Dr. Bakshi and Dr. Piscatelli? What about a second wave that could come later toward the end of this summer or this fall? And is this becoming the new normal? In order to understand this better, I believe we really need to focus on what we're learning from testing. Not only the actual types of tests, but our ability to interpret the results. And that's the last point that I will make here. When we interpret tests, we have to realize that a test is a technological activity that we apply to people who either do or don't have a particular disease or condition. Whether or not they have disease is essentially not known. It's fundamentally an unknown, and that's why we're testing. The test is something we know the outcome of, and it's either going to be simplistically positive or negative. The test is yes or the test is no. And out of these 4 overall contingencies, we can have true positives, true negatives, false positives, false negatives. Let's face it, the patient, the clinician, and the pathologist all want these green boxes to be as large as possible. We want negative tests to be true negatives. We want positive tests to be true positives. And the manufacturers of the tests will report the outcomes in terms of sensitivity and specificity. That is the only way they can really report the effective characteristics of the test that they provide. The problem is that for us as clinicians and for us in an outbreak situation, we don't need to know, and it's distracting to hear the sensitivity and specificity. What we really want is the positive predictive value. We're faced with a positive test. What does it mean? Is it true or is it false? We're faced with a negative test. Is it false or is it true? So let's take 2 examples. In one case, the disease in question is highly prevalent. This means that the yes column will be more populated than the no column. You can see smaller letters over here, which means both true positives and false negatives are going to be more common statistically just because there's a lot of disease going around. This means that with highly prevalent disease, the positive test is going to have a very high positive predictive value. So tests are most useful when there's a lot of disease around. Take the opposite situation in which disease is rare. When we're testing for a rare condition, true positives and false negatives will both be uncommon relative to false positives and true negatives, meaning that the ability of a positive test to predict a positive existence of disease is quite low. This would be akin to testing for strep throat disease in the middle of the summer when most children do not have strep throats. And so the effectiveness of the strep test is lower. Overall, there are great benefits of wide testing to identify the patients, refer them for management, identify the seropositives or immunes, and characterize the dynamics of COVID-19 to create that COVID page in the manual of infectious communicable disease. Here it is today. This is the current edition put out by the APHA, the American Public Health Association. And this is the page that currently at best is in draft form. We know the etiology of COVID-19. We know its worldwide distribution, but many of these parameters are not known. And so this page is at present full of question marks. How far will this go? We will have to depend on how much immunity, how much of a second wave, and how much of a new normal we have to embrace based on this missing page from the Communicable Disease Manual. Thank you.
Good afternoon. I'm Dr. Marissa Montecalvo, and I'm going to be speaking to you about clinical pearls for when we will return to work. I have no conflicts of interest to disclose. So in discussing clinical pearls or things that we've learned over the last 2 months as we begin to think about returning to work, I wanted to focus on 3 issues that have become clear over the last 2 months. The first, as you've already heard, is that pre-symptomatic or asymptomatic transmission with this disease can occur. So unlike the first coronavirus, SARS, where people had peak viral loads a week and a half into illness and were sick and were already on isolation. The second SARS coronavirus, or COVID-19, it's clear that there are high viral loads at the beginning of illness and even before patients are symptomatic. And this slide here shows you a report from Singapore where patients A1 through A5 were all in the same church. Patient A1 and A2 had come from Wuhan and were in church together. And later that day, patients A3, 4, and 5 were in the church. They were all asymptomatic on January 19th at the beginning. And the subsequent dark blue boxes tell you when they developed symptoms. But patients A3, A4, and A5 did not have any other exposure other than this church on careful epidemiologic investigation. So this was one of the first reports that really started to say that there could be, or likely is, some pre-symptomatic transmission going on. This became evident on a much greater scale in this study, which is from the first outbreak in the United States at a long-term care facility in Seattle. This was published in the New England Journal, where the group went and did a point prevalence survey of residents at the long-term care facility. Regardless of whether they were symptomatic or not, they had a nasopharyngeal swab performed, and that was on day 0. And of the 27 residents who were asymptomatic and subsequently became symptomatic, they could detect virus 1 to 6 days before symptom onset. So this is really something that you know, but I think is one of the most worrisome parts of controlling COVID-19. And what it says to me in terms of going back to work is that we will not be able to bring our guard down. You don't know who could have had COVID-19 transmitted to them and who could subsequently be developing symptoms. The second area that I wanted to touch upon was that the disease manifestations are evolving. So the poster here on the left was the original poster that we showed at the first Touro Symposium, where the case definition was fever, cough, and shortness of breath, fever, cough, or shortness of breath with an epidemiologic exposure. That has now been expanded, as is often the case when you have a new disease. The definition gets refined over time. So the current epidemiologic definition is at least 2 of the following: fever, chills, rigors, myalgia, headache, sore throat, or a new smell or taste disorder. Or one of the original symptoms, cough, shortness of breath, or difficulty breathing, or a severe respiratory illness for which there is no other diagnosis, and potential contact to COVID-19, which of course at this point could be almost anywhere, but close contact is defined as within 6 feet for a period of about 10 minutes or more, depending upon the exposure. The other aspect to the disease evolving, and this has also been touched on previously, is that there are complications of this illness that remain somewhat unclear, and there is much to be learned. So from early on, there were reports of myocardial injury in association with COVID respiratory illness, hypercoagulable states leading to stroke or pulmonary embolus. There's a recent report of COVID toes, which is actually a discoloration of the toes that could be vascular, that appears to occur after symptoms of infection have often resolved. And it's unclear what the etiology is, but maybe once again, one of these inflammatory conditions in association with this disease. And lastly, I just want to spend a moment on the issue that there has been severe disease in healthy persons. So although we say that 80% of illness is mild, and although we say that severe complications are often in the elderly or in those with underlying conditions, there also are severe cases in healthy persons. And that I think really gives us pause for how little we understand. And there may be almost a silent desaturation going on, which might be why people are presenting to the emergency room in such a critical state. I want to just point out to you this article, which is not from a scientific journal, but from a great journal, the New York Times, that was published on April 20th, which is the story of the first patient admitted to Massachusetts General Hospital, a 47-year-old avid skier in terrific physical shape who spent 32 days on a ventilator and received extracorporeal membrane oxygenation. It is a riveting story. It ends beautifully. He leaves the hospital. But it really explains the decision-making day to day and the complexity of what was involved in the management of this patient. And so I just wanted to point that out as we think about the complications and how little we truly do understand of this disease. Third and lastly, antibody testing is a great step forward. And as Dr. Piscatelli already told us, there's a lot of variability in the tests, but with good tests, it can give us some very good information, but the information is regarding prevalence. It's not about the potential for transmission or safety or a card to return to work. The New York State Department of Health did a sero survey outside grocery stores about 2 weeks ago. They have an excellent test. They sampled about 3,000 patients, 3,000 people, and you can see the prevalence there. The statewide prevalence was 13.9%, Westchester 11.7%, and the city 21%. These are very useful data, very important, but on an individual level, it only will help you understand if you've been exposed. And lastly, I just wanted to say that we remain with the issue of being very careful for isolation, of maintaining isolation for any symptoms of COVID. The removal of isolation is usually done based upon symptoms, and just a few days ago, CDC expanded this from 7 to 10 days, that anyone with presumptive COVID infection or with diagnosed COVID infection is to remain isolated at least 10 days after illness onset. That's expanded from 7 days and must have at least 3 days of complete recovery. And the reason for this was because in studies, they could still detect viable virus that could replicate 9 days after the onset of symptoms. So these numbers may change, but social distancing and isolation for those who become symptomatic, I think will remain with us for the foreseeable future. So in terms of returning to work, I think we have to be prepared for symptom screening, recognizing that we may not even know all of the symptoms. There will be face masks. We have to be scrupulous about enhanced disinfection and hand hygiene and not let our guard down. 6-foot distancing is there. And I think it's just really important to remember the great limits of what we currently know. And I took this picture from a place that I visited recently. I thought it was very useful, actually. It's hard to remember exactly what 6 feet is. So this may be something that would be useful to have in some of our workplaces.
This is Dr. Shirlita Amler. I'm the Commissioner of Health for Westchester County, and I have no disclosures. So here in Westchester, we are trending downward, seeing fewer cases of COVID each day, fewer hospitalizations, fewer deaths overall, and fewer people asking to be tested. but we all know that the restrictions are still in place. And as New York State begins to relax some restrictions, the governor has predicted that New York City and the surrounding counties, including Westchester, will lag behind the rest of the state. Meanwhile, all counties are preparing for the day each county eventually opens up and comes off the governor's pause. The next challenge will be active surveillance as people come out of their homes and go back to work to recognize any new chains of transmission that emerge and be able to react quickly and definitively. To that effort, New York State is launching a new, ambitious effort to curb the spread of COVID. The aim of this initiative will be to call every confirmed case, establish all of their contacts, and maintain ongoing communication with each one. In addition, the team will support isolation and quarantine as needed, including checking the individual's needs virtually and helping them access community resources as needed. This contact tracing will fortify efforts to control the pandemic here in New York. It will work in tandem with statewide efforts to increase testing and improve knowledge of efficient strategies to reduce transmission. Students, take note. New York State plans to hire a team of 6,000 to 7,000 people statewide to do the contact tracing. Recruitment, interviewing, and training will be supported by Bloomberg Philanthropies, the Johns Hopkins Bloomberg School of Public Health, and Resolve to Save Lives, which is the Tom Friedman NGO. To be considered, you must be a New York State resident, 18 years of age or older, meet the position description requirements, go through an online interviewing process, and complete an online training and certification program. Team members will fill the following roles: contact tracers, who will reach out to the contacts of anyone diagnosed with COVID to assess symptoms, ensure compliance with quarantine, and determine social support needs. Team supervisors, who will each lead a team of 20 contact tracers plus one community specialist who will work remotely using digital tools. The community support specialists themselves will address the physical, mental health, and social human services needs of those contacted, especially those who are under isolation or quarantine orders. In addition, Westchester is recruiting for an epidemiologist to oversee data collection and perform data analysis and interpretation. Please watch our website for this position posting, which will be coming soon. If you are interested in any of these opportunities, you should go to our website, which is health.westchestergov.com, and look for the link that says Become a Contact Tracing Team Member. Thank you.
Thank you, Dr. Amler. For those of you who joined us when the program was already underway and wish to apply for your CME credit, the slide currently being shown shows the instructions as to how to apply for continuing medical education credit. Text the code 25 in all capitals NIXY to the phone number 828-295-1144, or go to www.eeds.com, click the sign-in button, enter the code, and you will receive, in either case, if you either send a text message or if you use the www.eeds.com website, you will receive subsequent instructions as to how to get your CME credit, how to fill out the questionnaire, and how to get your certificate emailed to you. I want to thank all of our panelists for their excellent presentations, and we'll now turn to the question and answer session of our program. A large number of questions came in advance of the conference at the designated website, and we're going to respond to those that were emailed in over the weekend and up until Monday. In order to speed up our Q&A, we're going to skip a lot of back and forth of me asking each individual question to each of our panelists. I'm going to read all of the questions for each panelist and then take myself off the screen so that the panelists can respond. Our first set of questions are for Dr. Janet Piscatelli. Dr. Piscatelli, the questions for you are, I'd like some more information about blood donations and blood transmission of the virus. I live on Long Island, and there's a blood shortage, and they're looking for donors. Can the virus be transmitted by a blood transfusion? If I was tested for the virus and I'm negative, can I donate blood? If I was tested for the virus and was positive, will I donate blood? Do I need to worry about this virus being transmitted by blood-borne transmission by mosquitoes from person? And the other provider, and I've been doing telemedicine visits with my patients, is there a laboratory test you can recommend that I undergo before returning to face-to-face patient visits? Thank you for those questions, Dr. Piscatelli. The floor is yours to answer these questions.
So these are some really great questions, and I'll take them one by one. So the first one is, can the virus be transmitted by a blood transfusion? There are no data or evidence that this coronavirus can be transmitted by a blood transfusion. And in fact, there have been no cases reported worldwide of transmission of any coronavirus via blood transfusion. However, out of an abundance of caution, the American Red Cross requires a person who has been exposed or exhibited symptoms to wait 28 days after symptoms subside before donating. If you're negative for the active virus using an amplification test and have not had exposure, that would be great for you to donate. It is a precious resource. If you have exposure, but yet has not been positive by PCR, you should wait 28 days before you give blood. The silver lining is, fortunately, this virus is not vector-borne and is not transmitted through mosquitoes. It spreads person to person, primarily through respiratory droplets. So we shouldn't worry about getting COVID through mosquito bites. For the healthcare worker who's doing telemedicine and wants to go back to seeing patients, I just want to reemphasize that there are some issues with the sensitivity and specificity, and there is no definitive evidence that equates positivity with protection. Having said that, at the present time, if a person tests positive for an IgG antibody test using a robust assay, this indicates that the person most likely has been exposed and mounted a response. This person can be cautiously optimistic. However, they should still continue social distancing, washing their hands, and wearing a face mask. Thank you.
Thank you, Dr. Piscatelli. Our next question is for Dr. Bakshi. Dr. Bakshi, what are the key issues in designing a vaccine for COVID-19? Will you make any predictions regarding if we will have a vaccine? And if so, how long will it take us to have one? Dr. Bakshi.
That's a really good question. So vaccine development is a very complex and long-drawn process. So you have to have first an appropriate viral antigen, which can be used as a component of the vaccine. And then you have to know or have an understanding of So you have to have an understanding of the immune response that this vaccine is going to induce. And then based on these two combinations, you formulate the vaccine and then look for the stability, safety, and see if the vaccine is not inducing any adverse reaction. And after doing these preliminary steps, the vaccine will go for a clinical trial. So it's a long run process, but the best thing about this current outbreak is that things are moving at a very fast pace. And there are like at least a couple of good vaccines which are in clinical trials now. But as I said, like in biological sciences, nothing goes as planned. So optimistically, if everything goes according to the plan and that the vaccine is protective, then maybe, it's still going to take at least a year that a good vaccine candidate is available, or maybe more time depending on how long it takes for the commercialization. Thank you.
Thank you, Dr. Bakshi. Very helpful. We have a few clinical questions for Dr. Marissa Montecalvo. I'm going to read them all so she can answer them all without us going too much back and forth. Dr. Montecalvo, what's the significance of an elevated D-dimer in COVID-19 patients who are at home and without respiratory symptoms? Should these patients take factor inhibitors? Why was hydrochloroquine thrown about as an antiviral, and what was wrong with it? What were your thoughts about remdesivir, a drug meant for Ebola RNA, and how does this drug affect COVID-19 RNA? Dr. Montecalvo, we look forward to hearing from you.
Hello. So I'll address these in order. So regarding the significance of an elevated D-dimer, so it is, as was mentioned, hypercoagulability can be an issue with this infection. And in fact, when patients are hospitalized, a D-dimer is checked routinely, and they could certainly would need anticoagulation if there was any evidence suggestive of hypercoagulability. In a situation where someone is asymptomatic and has a D-dimer checked, I mean, that would really be why was the D-dimer checked to begin with, and that would be really an issue that they would have to discuss with their physician. If they're asymptomatic and have COVID-19, I don't know that it's clear what should be done. I think it needs to be followed, and if there's any suggestion of an ongoing that it's continuing, they may need they may need treatment for that. That has really been looked at much more in severely ill patients. Regarding the question of hydroxychloroquine, so hydroxychloroquine was a very interesting drug because it appears to have the capacity to block at the receptor level where COVID-19 is attaching to the ACE receptor, and that's a very attractive place to interfere with a virus at the point of binding to the receptor. But like all of these drugs, it has to be studied in randomized clinical trials. There was a little bit of data that came out suggesting that there could be a benefit from treatment with hydroxychloroquine, but it was a non-controlled study, and the drug can have potential toxicity. It can prolong QT intervals. It has to be used cautiously. So it is not clear what its utility is at this point. And as has been said by the Infectious Disease Society and by many other groups, the use of these drugs requires use through a clinical trial. And similarly, remdesivir appears to be a very promising drug in that it will interfere with RNA replication. And in the trial that was recently published on its use as compassionate use, meaning severely ill patients who needed the drug were able to receive the drug, it appeared to be beneficial and to reduce the duration of symptoms and improve outcomes. But again, we are awaiting data through randomized trials.
Thank you, Dr. Montecalvo. We have a barrage of questions next for Dr. Robert Amler. Dr. Amler, I'll read all of them. Some people say that summer months will reduce or eradicate the virus. Do you agree? Is there anything about this question to be learned from Australia, where the summer months went from December to March? I heard the Australians did very limited COVID-19 testing, and maybe that data is not going to be instructive. Let me finish all the questions, Dr. Amler, and then you'll answer them all. The next group of questions Is the 6-foot social distancing rule really correct? Can the virus travel farther on a windy day? Is it possible for the virus to go greater distances? If your window is open, can the virus float in? Will it be safe for me to turn on the air conditioning? Will an air conditioner suck the virus into my home? And finally, the last question for you, we're being fastidious at our home about cleaning our surfaces. I, unlike my lovely wife, take my shoes off at the door normally. I'm getting tired of mopping the floors every day. Is there any information you have about how long this virus lives on blacktop, concrete, ceramic, floor tile, or stone? How about on other indoor surfaces like plastic, stainless steel, and cardboard boxes? So, Dr. Amler, we have a question about data from Australia, questions about the 6-foot social distancing rule, and then questions from a husband who wants to know if he has to keep mopping the floor and taking off his shoes when he enters the house. It's all yours.
Well, thank you for all those questions. I know some of them make us smile, but I think the reason they make us smile is these are very down to earth, what are you going to do today and tomorrow type questions. Talking first of all about the summer months, we would all love to see a relaxation of the intensity of transmission of the virus as the warm weather comes. But let's remember that there are parts of our country that have warm weather almost year round. And although Australia reported a milder hit from COVID-19, remember that data are often collected very differently in different countries and even in different states within the US, so that it's really not yet possible to know what is going to happen in July and August and early September of this year. We just don't know, and time will tell. In the meantime, we continue everything that we're doing as gradually state governments begin to relax some of the most difficult restrictions so we can get our economy restarted, which over time is going to become at least, if not as important, if not more important, to the health equation. In terms of the 6-foot distance, this distance has tended to work fairly well for respiratory viruses. If you're coughing or sneezing, most of those droplets will drop within just a couple of feet, 3 feet. A vigorous sneezer may propel a little further. There is nothing magical, perfect about 6 feet, any more than it is 6 feet, 1 inch, or 7 feet, or 5 feet, 6 inches. But 6 feet is a good benchmark, no pun intended, to keep your distance from other people, covering your face with a mask to protect the vapor that comes out of your mouth when you speak, prevent that from mixing in the air, seem to be important too, since we have case after case reported of people with documented COVID-19 infection who swear that they did not encounter anybody coughing or sneezing. So we have to presume that there was some virus in the air circulating that they picked up. Now, that leads into the next question. What about being outside on a windy day? Is the wind good or is it bad? Again, nobody really knows, but in general, dilution is a big solution to this type of problem. With a wind, we know from chemical dispersion studies, dust dispersion studies, and mold dispersion studies that a good steady wind can do marvelous things to reduce the air concentration of an infected particle or a toxic particle. So wind in general is going to be a good thing. If the wind is directly blowing from the nose of someone who's infected right into the nose of somebody standing there, obviously you could imagine that you could transmit virus that way. But that's considered to be a low probability situation, a low probability exposure. Now, what about an open window? Well, if an open window was enough to blow a little wayward virus particle floating around outside your house or apartment, get it in your window and get it into your respiratory tract, I would say that was a very rugged little virus indeed. I doubt very much that that's possible, although as you know in science, we never say never. But I would say, pardon the expression, if that was the only mode of transmission we had to worry about, I don't think we'd be as worried as we are today about the more direct transmission between people who are too overcrowded and too closed in indoor spaces. There's no evidence, certainly, that air conditioning will worsen the situation, except to say that the cooling and drying that occur in air-conditioned air, and this is from studies I helped do at the CDC on measles many years ago, another virus that's spread by respiratory route, that if anything, air conditioning and the drying that occurs with air conditioning, that it makes it more difficult, not easier, for viruses to spread, remain viable, and infect other people. So air conditioning should be okay, but again, we're learning more about the virus every single day. To the questioner who posed probably the most interesting question of all, that seemed to border or touch gently on his marital situation, I don't want to get in the middle of that, but what I will say is that we really have not seen any evidence that transmission of virus from asphalt, blacktop, sidewalk material, again, if things have landed on those surfaces, they are far less likely to get remobilized into the air and to remain viable. Nobody really knows the answer, but I think that this is a case where you want to do everything reasonable to block exposure to your nose and mouth and face, use common sense, and do the best you can. Thanks for all those questions.
Thank you, Dr. Amler. I have received a few comments on the chat line from people who want me one more time to show the CME information. So one more time, for those wanting CME credit, text the code 25NIXY to 828-295-1144 or go to www.weds.com, click the sign-in button and enter the code 25NIXY. In both cases, you'll receive instructions and follow up as to how to get your CME credit, fill out the questionnaire, and get your certificate by email. We're now going to hear once again from Dr. Alan Kadish to offer us some summary comments about our presentation and our Q&A. Dr. Kadish, the floor is yours.
Thank you so much, Dr. Halpern. I'll summarize briefly, which to say is we've learned a lot, but we haven't learned enough to feel that we have dramatic interventions other than social distancing, wearing masks, using hand washing, using disinfectants to affect COVID-19 pandemic. So first I have a couple of questions about some of the things that were raised, and then I want to try to get some advice from the panel that's kind of personally institutional, let's put it that way. So the first question for Dr. Sharita Amler is, you talked about the very impressive contact tracing program that the state plans to put in place. How low of an incidence of the virus do you feel we need for contact tracing to be practical? Because obviously during the height of the pandemic, when there were thousands of cases a day, contact tracing would have been very difficult.
Most useful answer.
So I think that initially, as you said, the numbers were just impossible for us to do contact tracing on. But now we're getting down to a number I think we could do contact tracing on. And the most important thing is if we can do it in real time. So, you know, when we were getting results back that were days, a week old, it was really difficult to work on those. Now that we are to the point that we're getting the results the day after the tests are done, we can actually reach out to people, put them in isolation, try to find out who they might have exposed and have a conversation with those people and get them into quarantine and try to avoid further exposure, because really, as we have said from the beginning, if you have no exposure, you have no risk. So if we can prevent future exposures from people, I think that that is a way to contain this until we do get a vaccine or drugs that are more efficient. So I'm very hopeful that this is something that we can manage. It waits to be seen. I think that if we can get a large enough group of people involved so that we can do this in real time, I'm very hopeful that it will work.
That's great. What do we do as the state begins to open? Does the panel have any recommendations about what to do about the New York City subways, which are obviously a place where, even though there's limited data, there's a strong suspicion that those will be places, based on what we know about disease transmission, that things could certainly move away pretty quickly in terms of disease transmission. So no one's jumping in, and what I would suggest is that means that this is a problem that requires a better solution. I think what's going to be very clear is that distancing to the extent possible, wearing masks, and disinfectants are going to be crucial, because we don't really have a good way to maintain social distancing. And as has been pointed out, there are a few people, even without symptoms, and even who've had the disease for a while, who still may be transmitters of the disease. So finally,
let me break in. There's been a related question that's come into the chat room for what Dr. Kadish just raised. Dr. Sherlita Amler, I have a couple of people on the chat room saying, can I sign the children up for sleepaway summer camp? They want deposits. What am I supposed to do about that? Do you have any thoughts about anxious parents who want to know about whether the children could be sent to summer camp, not dissimilar from worrying about the subway? I suppose some parents are be more than happy to get the children out of the house.
Well, I think we need a lot more information about the Kawasaki-like syndrome that is just recently been reported in New York City and other locations. And right now, I just don't have enough information. I don't think the state does either. And so we're really, looking, we're about to put something out across our website to providers in regards to this, and looking for providers to provide us information so we can see, is this a real problem? If so, how serious a problem it is. But if that is the case, then I think that will have an impact on whether children go back to summer school this summer or not.
All right. Thank you, Dr. Halpern. So the question I want to close with is a question that many of my colleagues are grappling with, and I'm grappling with, is given what we currently know, and this one I will ask the panel to weigh in on because I need help. Given what we currently know, what should we do about schools, elementary schools, high schools, and colleges come the fall? And elementary schools and high schools may be able to make a decision on a relatively short timeline. Colleges really need some advance warning because a lot of the students come from afar. So does anyone have a sense about what might be possible or what we can potentially do at the college level starting in the fall? So Rob, you've jumped into the picture. Why don't you weigh in?
I can weigh in, but I really don't have a definitive answer. I think what the other Dr. Amler said a few minutes ago is without enough information of the real risk involved, it's hard to make a prediction of what we will or will not be able to do in the fall. I can say that here on the campus of New York Medical College, and Dr. Halpern may want to add something on this, we're doing everything possible to preserve the possibility of in-face, in-person instruction for things like anatomy, physical therapy, clinical examination, physical examination, and so forth. Things where you really have to be right there with other people to learn. Trying to preserve that we can provide that kind of instruction with some kind of additional protection for the students as well as the faculty and any standardized patients. And wherever we have classroom instruction, to either do that in less dense environments so that people can still be 6 or more feet apart in a class, and or more online instruction so that people don't have to come to class in the first place. It's very different for an undergraduate institution, for a graduate health sciences institution like ours, K through 12, because so much of education is socialization with your peers and classmates. So over time, if we cannot get our arms around and reduce exposure, we are going to have to really look creatively at other ways of educating people. And I think long-term, it could be very problematic. Sorry.
Anyone else want to comment? Okay, so I'm going to thank the panelists for their input here. I think what we've shown is there's been progress, but we have a lot to learn. Our own approach has been that because of the uncertainty, we're going to wait as long as possible to make decisions about how to approach returning to the workplace, returning to school. Obviously, follow state guidelines, listen to guidance from the state, but try to understand that it's not that we get any smarter, but we just learn more every week. And just as there's been a big difference in some of the recommendations coming out from the CDC, as well as the recommendations that we've discussed at these COVID conferences every few weeks or month, in a month or two, we may have learned a lot more. We may have better point of care testing using rapid PCRs so that we can detect the virus in a few minutes, which would certainly make a difference in the way we can manage things. And we hope that the accumulated scientific knowledge that you've heard about today will allow us to get a better handle on what's really been a terrible disaster, with tons of people we know passing away and a tremendous disruption to people's lives. Hopefully the science will let us do better. Dr. Halpern.
Thank you, Dr. Kadish. I'm sure all of those of you who are listening and watching this afternoon want to join me in thanking Drs. Kadish, Bakshi, Piscatelli, Robert Amler, Marissa Montecalvo, and Charlita Amler. Thank you for your questions. Please, those of you who are going to do the CME form, please fill out the comment part of the questionnaire so we can have your feedback and continue to improve these conferences. That will conclude our program for this afternoon. Thank you for listening. Thank you to our panelists, and thank you all for joining us this afternoon. Bye-bye.
Thank you.